Yes.
Share my slide first.
Sorry, Professor, maybe you can double click to enter because we cannot see your slide in here.
Okay, let me share again, yeah?
All right.
Can you see?
Not yet, Prof.
Okay, just wait for it.
If you don't mind, what if we help you to share with your
Okay, I send you the file. Can you just share from there?
okay, okay.
It seems
Yeah.
to be my, yeah, okay.
Okay.
Sharing first.
Yes. Is it clear, Prof? Sorry, Prof. I can see your slide now. Maybe you can continue your presentation.
Okay, that's better. You just click from there, yeah?
Yes, yeah, it's better, Prof.
So
Okay,
apologize
you
for
can
the technical
continue.
glitch. First and foremost, I would like to say thank you very much to the Dean, Deputy Dean, and all the lecturers and also the students. Assalamualaikum warahmatullahi taala wabarakatuh. Salam
Waalaikumsalam
sejahtera, salam
warahmatullahi.
Ramadan Karim. Today, I'm going to share with my knowledge and also experience with regards to my specialty. The title is Occupational Infections, and part of it is just the challenges in outbreak investigations. I'm sure the students and all in public health, we're talking about outbreak. That is the core things that we must know and able to deliver during field outbreak investigations. So I would like to just to highlight here, the content here is mainly by my experience and also my working as a lecturer in University of Sabah through publications. If you have any other things that would like to know, you to ask, you can ask after the presentations. Yeah. So can go to next slide. So the Ika is already elaborate about my a little bit of my biography. Of course, my task is mainly doing occupational medicines and also teaching students medicine, doctor medicines, and also those is a postgraduate level for the master public health, doctor public health, and also become a consultant for the Ministry of Health with regards to the policies and mainly about the communicable disease in occupational health. Next. So the scope of the presentation is just a bit narrowed but by looking into the levels of the participants, you all mostly, they're all undergraduates. For those who's postgraduate students, if you want to ask further, maybe for you it's just revisions, you may ask after this. So the content is just is about what is the occupational infections, and we're talking about the outbreak investigation and what is the common thing in Southeast Asia. We are in Malaysia, Indonesia, Brunei, Philippines. We have some common things, yeah. And the key topic is about the challenges. I hope that the students here, once you graduate, so you're working at the Ministry of Health or whatever entities, there are a lot of challenges, things that you need to prepare. So the most important thing is how you want to strategize to make sure that you are able to do a task as ordered by your superiors. Can we go to the next slide? So what is occupational infections? When we talk about occupational infections, is a infection itself, yeah, acquired during the course of work due to exposure to the biological agents. So when we talk about the agent here, they are all causing infections. Yeah, it can be bacteria, it can be viruses, can be fungal, or can be parasites, or it can be like a snake. Yeah. So this is a thing that during the work, you get these infections. That's why we will talk about occupational infections. But there is a two component we have to understand about the occupational infection. It can be due to the germ itself or the agent itself. Yeah. For example, like anthrax. Yeah. It can be due to that. Yeah. Or it can be by the area where you live in, or you're going to investigate.
Hi.
The organism is associated with the workplace or occupational setting. Yeah. So it can be the germ itself, or it can be happen in that particular environment. Yeah. For example, like leptospirosis is already there in the soils. Yeah. So they are anytime can cause occupational infections. So basically, we're talking about this is one of the subspecialty in occupational health. Can you move on to the next slide? So why we really need to know these occupational infections? Because we really need to control. That's why we are in public health. We are not in the hospitals. We are trying to control the infection at the source. Yeah. Where is it? It come out from where? Or it can be we control through the route of the transmissions. Yeah. From point A to point B. So that is a route. Or, for example, like is another from the animals, it go to the humans. Yeah, so that is another route. It can be different form of route. Yeah, it can be by air, it can be by water, it can be by food, or any type of vehicles where actually can transport the germs to another entity. And the third control is try to protect the susceptible workers. So anytime when you do outbreak investigations, bear in mind that your task, your aim is all these three things. You try to stop the germ from the source. Sometimes it's very difficult because we don't know where's the source. But we can still stop it in the middle of the road. Yeah, the route of the transmission. We can just stop it anytime. Or we can cover the human by wearing the PPE. That's how we protect the susceptible workers. Yeah. So from there, actually, the best, of course, is number one, we can control the source of infection. But in reality, it's very difficult. It depends on the quality of your investigation report. Can we move to the next slide? So we talk about infection in epidemiology. I'm sure you're aware about this epidemiology triad: agent, host, and environment. But in occupational health or occupational infections, we also have agent, host, environment. But the agent we change to causative factors. Yeah, whatever causative factors. And then we move to host. It can be the people, groups or population and their characteristic. Yeah. And then the environment is the same. Yeah. You make it together with your behavior, the culture, the physiological factors, and also ecological element. Yeah. So we have to understand this triad before you want to ask the questions. Sometimes when we deploy our team, we usually have some sort of preliminary discussion first. How is it? Is it we know the source? We know the germ? We don't know the germ? You know the people? Of course, the people, you already know the magnitude. We know the environment is already changed. Then we try to look into that. What are the things that probably it can be airborne? Remember just I said the route between this triad transmission. If you know like airborne is very easy for us to control. Yeah. You know the water. If you know that it's through water or through the food or any vehicle, it's very easy to control. But if you don't know about this, the causative agent, we just control through the transmission route. So the mode of transmissions in occupational health, mainly through the contact with animals or animal product. Yeah, that's how we call it zoonosis. Yeah. Now, with the current era, the communicable disease, more than 70 or 80% is due to the zoonotic origins. Yeah, means that from the animals, yeah, so they incubate in the animals or they just transit in animals and then they pass through the any mode of transmission and they pass to the humans. Okay, so probably I'm sure anyone here can know what is the examples of zoonosis. Are we allowed to ask questions to the members here? We can chat here. What is the example of zoonosis disease, which is common in your area? Anyone? So the mode of transmissions, if you know that by zoonosis is due to that. Yes, malaria, yes, but it used to be a vector borne. Yeah, vector. This is exposure to vectors. Okay, so when called to exposure to vectors, vectors here we means that is the mosquitoes. They need like a bus. They need a transport. Yeah, so they bite from human to human. Yeah, then they transport the parasite to the. But the current malaria, like P. nolizai, is considered zoonosis. Yeah, that is the current knowledge about this. So even in my area in Sabah, we have a lot of this zoonotic origin malaria. So for human malaria, like falciparum, vivax, malaria, they are all called human malaria. Yeah. So just now is through the human. Now the vectors is through the mosquitoes. Yeah. And the other one is care of patients. Remember that during the COVID in 2020 to 22, we have a lot of these, what we call the nosocomial infections. We need to make sure that the standard operating procedure will be in place because there will be a transmission from patient to the healthcare worker and also from healthcare worker to patient. That's why we always emphasis on hand washing between seeing a patient. The other thing is most of transmission is from the environments where we live in, yeah, from the soil. Yeah, in our soil, we already have a lot of this, for example, like leptospirosis. Yeah, so it can be transmitted, yeah, any time to the humans if you have the skin is already breached. So they can be transmitted anytime through contact. Sometimes through when you go to the stagnant water, also you can get this infection. The other thing is for the occupational infection is through the skin infections. Yeah. So it can, if you have these diseases from well, mostly for those who's working in the hospital setting. So this is just a bit of the basics as talking about occupational infections. We know how is it transmitted and what is the mode of transmissions. Okay. Next. So what is the importance of when we do this investigation? Remember, I told you we have to identify the source and try to know that the transmission route. Yeah. Then we have to implement the control measures to prevent further spread. I would like to advise the student here, if you place in the probably a CDC or any communicable disease or Ministry of Health, when you're deployed to investigate, yeah, you have to remember these two things. Find the source. If you don't find the source, you find the transmissions route. Okay, that is one. Second thing is you need to place the control measures to prevent further spread now and in the future. Because sometimes when I see like my counterpart in other district or province, you always investigate the case, but they will repeat again the way they investigate. In the end, we can see the case again. For example, I'm sure in your area, there will be a same school have a food poisoning. There will be a same probably workplace have the outbreak. Will be a same kindergarten who have HFMD outbreak. Yeah. So we are very important that when you do investigation, targeted to the source or root, and also try to prevent future outbreak. If there is another outbreak happen, then you have to relook again your quality of outbreak investigations. Can we move to the next slide? So in Asia, Southeast Asia, how is it the landscape of this occupational health? Yeah. We know that we are in Malaysia, Indonesia, in Mekong area. We are all agriculture. I think everyone is agree. Everywhere we can see the green. Sabah, the main contributor of palm oil for Malaysia, all green. Yeah, so it can be a small farmer, or it can be industrials, cocoa, palm oil. The second thing in the industry is healthcare. Yeah, it can be hospitals, it can be clinic levels, yeah, or can be informal settings. Yeah, it can be healthcare center. And the manufacturing. Okay. And also the high prevalence of informal labor sectors. So we can see here that most of the time, the occupational infections is the best medium to spread when look into this industry, especially those in the informal sectors. So we have to bear in mind that when we posted to the areas in this setting, that the spread of the disease will be quick, faster, and sometimes very challenging for us to identify the source. Yeah. Next slide. So what is the common infections? For the healthcare associated infection, we know that tuberculosis. Yeah. So a lot of TB patients will go to the clinic to get a treatment, screening, X-ray, everything. And our healthcare worker will see them every day, every time for treatment or for the screening. Yeah. So it can be happen, the exposure, probably you get it 6 months ago. It can be today you are exposed to patient who have TB and tomorrow will get no. Because there will be a phase for the incubation period up to 6 months for them to develop the TB. The same goes to hepatitis B and C. This is through the blood. When we take a blood, there is a study shows that most of the new healthcare worker in the first year of working in the hospital, you always have sharp injury or what we call the needle stick injury. So we are now, it's very difficult for us know the status of the blood. It can be HIV, can be hepatitis B or C, can be transmitted to them. Next is about zoonotic diseases. That's why I think just now we're talking about the avian influenza. Yeah, from the poultry workers and from the infected birds. Yeah, and also from Nipah virus transmitted from bats to pigs and then to the farmers. Yeah. So please read about this Nipah virus because we are the one in Malaysia. There's a story, the history behind this Nipah virus. Yeah, because we don't know about this disease. We thought that it's Japanese encephalitis outbreak. So we send a team to just do a fogging to make sure that it's probably due to vector, the mosquito will die. But we can see that the pig and also the human also still affected. Means that the root of the transmission still not be suppressed or been stopped by the healthcare worker. The third one is the waterborne and vector-borne diseases. As I mentioned, like leptospirosis, yeah, because of the agriculture workers exposed to the contaminated water, and also dengue fever, those who's outdoor workers susceptible to the mosquito bite. So mainly if you have this is the common things, common, always common. If you know that those in hospital, try to investigate, not you have to zoom this to TB, airborne, it can be to blood-borne, if you have BFC, or it can be outside, you can see that probably due to the animals. Yeah, it can be due to the bird, avian influenza, or it can be due to bat, Nipah virus, yeah, through that transmission, or it can be from the water, or it can be through the mosquitoes. Next. So now we go to the main topic. What is the challenges? If you're giving a task, yeah, to the field, I'm sure you'll know already the 10 step of outbreak investigations. Yeah. You know what is the outbreak means, then what is the purpose of investigations. Okay. I'm not going to that detail, but I just go to the points of challenges. Can we go to the next slide? So the first thing is when do this outbreak investigation, what is the challenges? First is the very high intensity epidemiological investigation task. The task itself is really heavy burden. Why? Because number one, when you do preliminary investigation, it will take around 1 to 4 hours. Yeah. When we go to deploy, when we receive the notification, there is a number of cases presented with probably fever with rash. Yeah. Maybe 3 people in one village. Yeah. So you try to make it establish whether there are outbreak or not outbreak. We need to establish that first. Yeah. So then you will send a team to do some sort of preliminary investigation. Yeah. So once they establish, yes, there is same time, same place, these 3 cases, there's an outbreak, for example, so measles outbreak, for examples. Yeah. But they will be take time because sometimes you go to the remote area or to the workplace where actually difficult for us to assess, they will take a lot of time. Yeah. And then after you have this preliminary investigation, of course, you need to complete the investigation. So to complete the investigation, you must be within 24 hours. So sometimes you can see that CDC, they will stay overnight to make sure that they will understand the disease itself. Yeah. So how is it? Is it a waterborne? Is it a vector-borne? Or it can be a source? So they have to quickly try to identify the contacts, to the close contact. Yeah, you know that the close are the three type of contacts. So they will try to identify the contact. You can see the magnitude of the outbreak. Then the other thing, you need to ask the history for the 14 days activity. It's sometimes very difficult for us. Even us also, if you ask you what is actually your food last week, mungkin day 2 or day 3 of Ramadan, when you breakfast, what is the food you eaten during that? So very difficult for us to get the accurate history. But having said that, even though that is a challenge, but remember, we are always focusing on what is the source, how was it the root like, and what is the thing that we can protect the some of the susceptible participants. Okay, can go to next. So this is me, not the takluk lahadatu. In 10 years ago, in Sabah, in Malaysia, we have a so-called like a small war. There's just intruders from militants of Philippines. Try to it's become a problem to our country. So what is my role then? So as a CDC officer, I was called that few of our commandos, the army, have a fever. You don't know what is the source. So when I went there um, to the commandos, there's few of them infected with the leptospirosis because the army usually the sole, when you open up the shoes, the sole usually have a crack. So once you have a breach, the skin breach, so when you on the barefoot to the soil, then very easy to be the heavily germs on the soil, leptospira can just transmit it directly to his barefoot. Then you develop the leptospira. They are during wudu. They found one water source, but the water source is not really hygienic. So indeed they develop leptospirosis. So if you get the chance to look into to watch the movie, I think last year the name is Takluk Lahadatu. This I think that is the real event in 10 years ago in where actually militants from Philippines want to claim Sabah. Yeah. So the quite experience to me because for the occupational setting, when we went to do this army, they have to the aim is not to be healthy. The aim is to protect the country. Yeah, so we can't really. Yes, we have to order them. No, we have to continue to become a frontliner for the country. So we have to be quick. We have to find the source. We jab them some medication, and then we control the environmental measure. Make sure they have a good water supply, so they won't have any uh, future spread to the other army. Okay. So next is about this is my experience by managing the avian influenza S7N9, where there is a Chinese tourist from Guangdong. He came to Malaysia and go to Sabah more than 10 years ago. That time we only familiar with H1N1. Yeah, we only familiar with H1N1. We not really familiar with S7 and 9, where actually they are avian influenza. Yeah. So by right, when you have the one we pick up, there's a fever, there's old lady, they have a tour, come to Sabah and visit few area. So they already went through few areas, tourist attractions. Yeah. So we went to tourist attractions and then a lot of area. By the time they come back to us, it's already 1 week. Yeah, it's already 1 week, and then we say from the history, they already have the onset when she was in China. When she was in China, but she wanted to join the trip. So the onset is before he's reaching Malaysia. So then our role is to make sure that you won't be further spread. But that time we are not sure S7 and 9, but because we need a more time to certain about these avians influenza, because we need to get a report from the internationals. So what we did is we quickly isolate her, yeah, so you won't be another spread. And then all the accompanied her in the group of 30 Chinese tourists. So we screen them, we take a blood, and we quarantine them for a few days. And we also asking about the history, all the few tourist spot, the whole Sabah. And we need to also asking them, do you have any other um, uh, all this fever? Alhamdulillah, none of them have it. So we only have a single case. But the thing is very difficult for uh, his conditions to be negative. So we don't really discharge her to China. Yeah. So from here, the challenges is when you receive notifications, where actually from the onset is very long time, then very difficult for us to certain about the how is it the magnitude like, how big is it the outbreak, how is it the close contact, yeah, is it able to capture the whole close contact, yeah, is it able to screen all the contacts, yeah. So and then the challenges for us to look into the source. Luckily when we say that they have a fever before that, then when we ask the China in Guangdong, so in Guangdong the practice is just cut just slaughter um, the chicken live. Yeah, it's not like, I'm not sure in your area, but they all have a live chicken and then the cut. So it's not really if there is a case, and there is a case in that area in Guangdong market, there is a case of H7N9. Okay, okay, next. So the second challenge is usually we know that like 3M, man, money, material. So this is because shortage of epidemiological workforce. Yeah, we can be because of this also. We shortage of PPE. Or sometimes we even our support equipment, like for example, like IT, it can be software or hardware is outdated. So when we talk about these things, sometimes very difficult for us to narrow, to focus on our investigation. So for example, like during the COVID, yeah, suddenly there's a number of cases coming to our area. So we need to isolate and then need to investigate. Yeah, we need to get this uh, the team for decontaminations team, yeah, medical team, investigation team, promotion team. So this will take a lot of workforce. Yeah. So usually if you have like this, we try to freeze some of the, uh, not to say not important, but it can be, for example, those working in non-communicable disease area. So it need to help the team, yeah, to mobilize, to make sure that we're able to control the diseases. The PPE, when there's shortage, I remember there are a lot of sponsors from the NGOs or company for the benefit of hacker, because we really need the PPEs. Okay. Okay, next slide. So this is an example where actually our outbreak, cholera outbreak in Kudat. So there are few cases from Philippines. I don't know if you're familiar with the sea gypsy. Sea gypsy means that people living on the boat. Yeah, they are not really belong to any countries, but they can go to any countries. Yeah, but I can see that they are all by accent is the most of them is the Filipinos. So what happened? They will go to the to jetty to any area. So you'll mix around with our local people, and you know that cholera can be transmitted to human. Then it's very difficult for us, yeah, to capture the who are actually the primary source, and also how we're going to stop the transmissions. But by this case, we quickly inform the authority, the port authority, to make sure that the sea gypsy need to be isolated, and then we give them prophylaxis for those who are not infected. Those who are already infected need to be isolated to give the medications, and also we give awareness to the public not to buy the food. Usually just selling the fish. That's why we are telling them. So we quickly got that. Next. The third challenges is usually the respondent is quite uncertainty. Yeah. Especially those who say for the past 2 weeks, what can you give us? Where actually you go? What is your uh the food diary? Can you provide us the food diary? So this is sometimes we call that recall bias. Yeah. Not only the recall bias, sometimes the respondent, it can be not really cooperative. Yeah, I remember last time during in urban area for dengue outbreak. Yeah, it's very difficult for us to to house, go for the fogging. Yeah, because they are all, yeah, you think that they are not really important. Yeah, so those who hold, they have a dog. Sometimes you have to use a dog to chase it out. So these are things that sometimes the challenges. Huh? The language barrier, this if you have the foreign cases, difficult for us, yeah, to manage. Okay, next. So this is the example of for the foreign, the challenges that now we have a case, biri outbreak. Yeah. So this is in the detention camp in Malaysia. So we have few inmates actually have this bilateral leg, so the both leg is swelling, yeah, and have difficulty and breathing. So when we make a diagnosis, it was very is due to the vitamins. So you're eating a lot of these noodles. You're not really eating rice. So there's no meat at all. Yeah. So we have a difficult to get the history, yeah, because of the language. They can't really speak English, they can't really speak Malay. Yeah. So this is the thing that challenges to us to get. So we take us few times, a few days to make sure that we able to identify the source of the outbreak. Next. The fourth is about the challenges is the impact on work and social life. We also humans, yeah. The public health workforce, the investigator also humans. So they might have a problem with the physical and mental health. That's why during the COVID, you can see that they work early around the clock. Yeah, you can't really go back home. Yeah, you can't really see the family. So it can cause burnout, stress, anxiety, depressions. Worst thing we can see, our colleague died during the outbreak. Remember, this thing is happened maybe once in a lifetime. in Malaysia is a lot because we are working in the ICUs. We are the one treating the patient. But very sad, we can see that some of our colleagues died due to the nosocomial infection. Yeah. Conflict, it can be happens. Yeah, because sometimes you can't really go back. Those is nurses in the hospitals, yeah, those who work in the public health, you can't really go back. So you have to deploy to remote area, so it can cause the family conflicts. Yeah. So for those who become a manager, or administrator, usually we have to anticipate this. That's why we send the psychological first aid, PFA, to make sure that they are really able to cope with all this burden. Yeah. Okay. Next. So this is my study among the frontliners. So we are also frontliners in university during the COVID. So it happened that they all have a lot of percentage of this having this stress. So we have to have a session with them to make sure that they are all will be treated well. Yeah. Okay. Next. The fifth one is the challenges is when we see we have a late prevention and control management. Why is it happen? Like just now, it's difficult for us to know when is it the onset. Sometimes we receive the case already happened 1 month ago. Yeah, it can be happen due to insufficient multi-department collaboration. Sometimes our counterpart, our colleague from other district province don't really inform us, or from the other agency not really inform us. So that's why you call that rumor surveillance is very important. Some agency only totally depends with the existing surveillance system, the former indicator-based surveillance. But that's why sometimes it's very difficult and quite late once we have this. Poor information sharing, this is a thing that sometimes happen, then can cause a lot of troublesome to others. If you look to this graph, yeah, for outbreak, if you can't really tackle at the early stage, that's why it can go up like the yellow things. So it's sometimes difficult for us to control. We need more people, more technology, more time if once come to the yellow area, which is usually more than 3 weeks. Yeah, that's why the KPIs usually once you investigate within 24 hours, you must able to investigate with the full information, and then within 3 days, you must completely do your control measures. If not, you're late in doing this, then the disease will spread and difficult for us to control. Then we wait for any mortality. Next slide. So this is an example, my case, a rubella outbreak among the trainees in National Service Program in Kelantan. Yeah, so it's happened that is one of the trainee, they have this family day. They are not really informed us, so that's happened quite late. We know that it causing difficult for us to control. So means that we can see already the peak during that time. Yeah, so always when we come to the institutional, we have to make sure that those who have an illness must report immediately. So this thing is not really happen, and then they keep themselves this disease, and then end up the whole trainees in the health service infected with this rubella. Next. And the sixth one is about limited surveillance system and underreporting. So usually we really need this surveillance for public health. Yeah. So if you don't really have this surveillance system, so difficult for us to anticipate, to predict. Yeah. So this is sometimes due to the underreporting. So we really need big data, need more information, so we can have this from respond rather than delayed or respond. Next. So I have a case experience outbreak of Zika. I'm sure you all know about this Zika in 2018 happened in suddenly in Malaysia also have Zika. So in Sabah also have one case of Zika. So I was deployed to investigate this case. Actually, the case, she was, I remember that time in Singapore, a lot of cases of Zika. So usually Zika and dengue more or less the same, isn't it? So in Malaysia don't have a Zika, and suddenly Sabah have a Zika. So when we see that, they are imported from Singapore. So when we do molecular tests, actually when we see that it's not really the Zika from Singapore, even though we asked from the history taking, but molecular test is due to that is already in Sabah already we have a Zika. But we never report because it's not under notifiable disease. So can you go to next slide? So we did the next slide. Yeah. So we did another study, journal population-based study to know where is there any existing Zika virus, seroprevalence of Zika virus among those who's living in the forest fringe. Yeah. Yes, indeed, it's true in our populations in Sabah, in Peninsular Malaysia. Yes, we already have Zika virus, circulating virus, yeah, among the mosquitoes, and also for people living in that area. So is that matter of time? So it can be outbreak. Okay, yeah, that's why we really need this surveillance. Next is the challenges is the high risk work environments. Yeah. So if you really high risk work environment, we know that is just now like those working in the informal sectors. Yeah. They don't really have in place of these um, standards for the to prevent SOPs. It can be transmission can be happen anytime. Yeah. Can you go to next slide? So I have this one case of leptospirosis. We did a molecular test, usually did MAT and also molecular test PCR among those who's urban sanitation workers. These are all working at the cleaning the like Dewan Bandaraya. In Malaysia called Dewan Bandaraya. So they all do sweeping or collect all these garbage, yeah, from the house, yeah. When we can see that they don't have the symptom, but the MAT is high and also PCR is positive. So we understand that yes, they are all have this germ, but they don't really have a disease, but they are already infected. So our role is quickly we check the symptoms. None of them have symptoms, and we have give them a prophylaxis. And when we repeat a test again, they become negative. So what's next? After that, we did risk assessments, right? So we did a risk assessment to look into that. So is there any areas that we need to improve? Because they went to the whole city. So is it due to the certain location or is it due to the areas where actually they need to be improved? Yeah, can you go to the next slide? Yeah, so we identify few, we follow up with this, so all garbage collector, and we do some sort of risk assessment, and we managed to pinpoint that, yeah, those is really a doing garbage collector is really need to be focused. So give them a training, yeah, supply with the PPEs. Sometimes it's very not practical, where actually they provide the PPEs. PPEs sometimes not really fitted with this the nature of the job. So we convey the message to them. You have to provide the shower before and after, and then probably if you have a symptom quickly, you have to go treatment immediately. Yeah. So you can see here we are taking a photos, but they are not really aware about us. So actually, they are not really wearing anything. So they are the one positive from time to time because they are all leptospirosis already in the soil and also in garbage. Next. And then the last one is about the challenges is about the cross-border labor. We have a lot of migrations, yeah. So it can be spread at any time, transnationals. Yeah. Okay. Next. So example is I have one case of malaria outbreak in one of the palm oil the rubber plantations. So when we investigate, we found out that's one of the um, uh, workers from neighboring countries. They're working there, so they have to be positive and causing outbreak among them. So they introduce the infections. But this is we always aware because we have a lot of this. We always anticipate those who's working coming from outside must be screened, and then they have to be treated accordingly, and they have to follow up from time to time. Next. And this is happened juga to the uh, uh, norovirus in kindergartens. When we receive a case that when we investigate and we do a test, and then we found out that uh, we thought that is from the norovirus from here. Actually, norovirus is imported in Europe, in Southeast Asia. So it can be someone bring in this virus. Yeah. So we know that now everyone can fly, everyone can go anywhere. So it can be spread the disease all over the world. Next. And this, I think that also the malaria. So yeah, Malaysia is already going to eliminate the malaria, the human malaria, but we can't really stop people also having this outbreak because same Plasmodium malariae. In remote area in Borneo, so we receive these cases. So we found out that also introduced by workers to that area. Next. And moms also among our students. So when we do a test also, then we thought it's local, so it can be so it's a lot of things that we don't really relate with the history. That's why for us, we wanted to combine history taking for and also the molecular epidemiology. Then we can really understand where is it the source. Next. So the strategy for us, we already know the challenges. I'm sure you also have your own challenges. This is my experience by managing a lot of outbreak. But alhamdulillah, most of outbreak is able to control well. So the strategy, how you want to make sure that all these challenges or what is about outbreak investigation will be done, not really ideally, but at least optimally based on your capacity. The first thing is you can just strengthening our occupational health surveillance. Yeah. So far what we have now is surveillance in the communicable disease. What we don't have this among the occupations. So it can be strengthened to develop systems, people working in that particular area. So we can just some sort of do a risk assessment. What are the probability type of infections that you can focus on that surveillance. Second thing is about the PPE. Yeah, PPE. PPE access must be available in stockpile because we don't know when is it going to happen. Yeah, usually we stockpile up to 6 months for the number of workers in our setup because we can't really manage the outbreak if we don't have enough PPE. And the third one, of course, we really need to develop the policy and collaborations. So you have developed the guidelines. So everyone will follow that guidelines and policy. Inshallah, they will able to improve the outbreak investigations. I think that's it from me for the so it's almost it's nearly 1 hour. So thank you very much for your attention. Semoga bermanfaat. So if you have any question, I'm willing to answer your question. Thank you.
Okay, you're welcome, Professor Safri. Thank you for a very clear and informative presentation today. It's evident that the challenges in investigating occupational infection disease are quite compelling, I think, yeah. And there are something interesting point that I note from your presentation is the talking about the new virus. Maybe I hear it's the first, the Nipah virus in Sabah and Sigipsis for cholera phenomena. It's very interesting for me. And it includes your experience in managing emerging outbreak like avian influenza, Zika, rubella, mumps, and other infection or outbreaks. However, overall, in Indonesia, might need to address the resource limitation to ensure this investigation adequately support to the program. But the challenges seem similar to Indonesia and maybe even more difficult, yeah, Prof. Okay, very interesting presentation, Prof. And I hope we can continue today. And we will now process with the Q&A session or question and answer, and beginning with 3 participants for the first segment. Yeah, and I have the note in here. And maybe from participant that Mr. Toras. You can open your camera and asking the professor directly, please.
Okay. Beforehand, I would like to express my gratitude for being able to join today's webinar activity, and thank you for the opportunity to ask questions. I would like to introduce myself. I am Toras Akbar Siregar. You can call me Toras. Currently, I am on my fourth semester, majoring in public health, Universitas Sumatera Utara. Professor, here is what I am curious about. What makes epidemiological investigation particularly challenging during an outbreak in Southeast Asia? And how do high intensity tasks complicate this investigation? That's for my question. Thank you.
Thank you, Torres. So your questions, first thing is about the how is it the investigation itself? It can be because the first is about the high intensity. We complete the investigation. If you really imagine how you run the investigations, when during the earlier phase, usually those who become investigator, the first 4 hours you do a preliminary, isn't it? So there are a lot of data, a lot of thinking, a lot of resource we need to be included in order for us to come up with the. So then after that, you need to come up with the complete report. What happened? How it can affect your investigation? If your investigation is not really able to find the source, remember the 3 things: the source, and then the root, yeah, and also for the who are actually affected, then difficult for us to come up with the whole story, yeah. Usually, I think for those who's become investigator, it's like a detective. We are disease detective. We just ask, we don't any looking into the format. Yeah. So where you go, where you, so it can be the source, it can be how is it the root, it can be the airborne, it can be. So if you see that, for example, people coming with vomiting and diarrhea or abdominal pain, and 3 of them is already admitted to hospitals. So they say is, your next question you may ask, they have a fever or not fever, or it can be due to meal you're eating, isn't it? It has nothing to do with meal. The other one is this. So it can be even a fever. It can be a virus gastroenteritis. Yeah. So you always come up with that thinking part, the scenario part, to make sure that you're able to focus and zoom. If you don't really able to come up with the quality of investigation, then you give a wrong message or inadequate message to the responder. I would like to share to you with regard to Nipah virus. We never heard about this Nipah virus. Nipah virus was in Perak, I think, in Perak, one of the in Peninsula area. We never heard about this Nipah virus. It's a novel virus. So they receive a notification, the pig is died. Okay. And then also they have those who's living in that area got fever. So what happened? They thought, oh, maybe it's JE. Yeah. So we know by knowledge Japanese encephalitis, it will be transmitted from the pig to human through the mosquitoes. Yeah. So what happened? You say, okay, possible is so you take it as a vector-borne disease. Vector-borne disease, responder will do fogging. But what happened? The disease, the number of cases among the human and also among the animals is increasing, despite you do few cycles of fogging. So then that time they are thinking, oh, maybe the phosphate, organophosphate is not enough. Then they look into that. Then finally they say, let's think of probably it's a new virus. Then found a new virus. They are not through the mosquitoes. They are through direct contact from the pig directly to the humans. Yeah. So this is a thing that when we do investigations, it's like we are like a policeman or detective. If you find the wrong, culprit, the wrong people who actually rob the shop, you just somebody that give wrong things to a message to other people. So make sure that we have to be prepared before you have this the actual cover investigation. Better to have simulations. Yeah, you have desktop simulation, field simulation. I used to have, I train my staff. So if there is a case came with fever and skin rash, what are the things that you need to do? Patient will come with nausea, vomiting, and diarrhea. What are you going to do next? So you will focus on your, so what I call that just now, high intensity task means that a lot of things need to be gathered, activities to come up with one informations. Did I answer your questions, Torres?
Okay, Torres, you got it?
Yes, Professor. Thank you for the valuable insight and explanation, and for answering my curiosity about this topic of occupational infections. Thank you.
Okay, maybe can help you to write your thesis or description, yeah? Okay, we continue, Professor. In here, that is Saudari Nisa Fadila and raised her hands, and you can ask him, Professor, directly, Nisa.
Hi, Audible.
Yeah.
Thank you for the chance for me to asking you question, Professor. Before that, that was a very good presentation, so I can learn from you. I'd like to ask one question. How do occupational infection affect workers' health, and what impact do they have on work-family dynamic and social life, in specifically in Southeast Asia? Thank you. That's my question.
Can you repeat the questions again? Yeah.
How do occupational infection affects workers' health, and what impact do they have on work-family dynamic and social life in specifically Southeast Asia?
Okay.
Am I correctly?
Yeah. Okay. So you're talking about the impact to the investigator, yeah? Yeah. So that's why I say we are we also humans, and we are working tirelessly without any formal working hours. We can work anytime, even at night. So how is it will affect us? Of course, it will directly, first thing usually will affect your mentals. your mental health. So that's why we always mention that if you really wanted to venture this field, you have to have very strong coping mechanisms. Your mental defense must be very strong. Because we can't really expect that only see a minor cases. It can be a lot of cases. That's why during the COVID, we see a lot of burnout. They're totally lost because they are really tired. But that's why we always mention to all the administrator, if we can change them every 2 weeks. Change the work areas, or we cannot be in same areas because they are also humans. So you will affect when you do things. Sometimes it routinely can affect their health. So when you can't really see mental health, you can see only the way they manifest. For example, suddenly they have this MC. Suddenly they can see what we call that is psychosomatic disease. From here, mental, but we can see the appearance, it doesn't really relate with any disease, but it's due to the mental health. So always engage. That's why we always have a roll call every morning to say hi to everyone. If you're really tired, make sure that they can have a good rest. Force them to take leave. And we replace with the other people, so we can the continuity of the task in the public health office will be there. So did I answer your questions? Yeah.
Thank you, Professor, for your explanation. It was helpful for me. Thank you for your
Welcome.
answer.
Okay, thank you, Nisa. Okay, Professor, maybe we can start with the first from the chat feature. It is here a question from Sonia Anissa Beruginting, and she is asking about what are the potential consequences of late prevention and control measure during an outbreak, and how do insufficient collaboration in poor information sharing exacerbate the problem. Let us talk about the potential consequences, Prof.
Yeah. So we know that just now the graph, remember I show you the graph. The opportunity on the left, the yellow. That's why when we always set the KPIs within 24 hours, you must complete your investigations. Quality investigation report. Means that you are able to identify at least the transmission mode. What is the route of transmissions? It can be airborne, waterborne. From the history, you will know. Second thing, do you know that where's the source? Most of the time, difficult to find the source within 24 hours. You need more time. You have to go there. Okay. The third thing, you need to see how many actually is already affected. Okay. So if you can have this information, you can straightaway go for control measures. So with control measures, you have to be immediate. Immediately. So within 3 days, you need to deploy a team. If you're airborne, then quickly we have to look into the workplace. Probably we need to evacuate the area first. You have to do cleaning. Usually what we call that decontaminations. We clean, we switch off the aircon, and then open up the windows. If there's a airborne, well, foodborne is very easy. If the food is from single source, it's okay, but it's multiple source, that's difficult. So we used to have last time due to the ice cube. When we drink the ice cube, isn't it? So there's one big company supply the ice cube to all the small shop. So once the one shop is contaminated, so the rest all can get it. So if you don't really pick up early, they'll become a full-blown outbreak. It's difficult for us to control. So that is really important to have early prevention, early control. Yeah. So the most important thing is you must get the help from others if you don't really able to control on your own. In district or in province, usually we have uh, water department. Yeah, it can be a land and survey department. Yeah, so because they have your own authority, so usually we communicate to them that please help, that we really need the shutdown maybe the water source because there's an outbreak of uh, cholera or E. coli. Then they will put up more chlorine. So this is how we communicate with all these people. If you're really late, then it can become a big outbreak. Sometimes it can be stopped by yourself. So that's why I think better don't waste your time. We just for the sake of investigate, but in the end, the control measure is not really done immediately. So it doesn't really serve the purpose. Yeah.
Okay, thank you, Professor. I think Sonia, it can help your question. And then here we got one more for this segment from Julfikar Abdul Aziz. Okay, come on, you can say your question directly.
Thank you for the question. So, sir, my question is, you saw us that a lot of outbreak happens, but there's a lot of outbreak happens before the COVID. Like, you saw us that mumps happens in maybe before COVID. I forget the exact year, but after COVID 19, we have a lot of improvement, uh, especially in people who care aware more about their healthy hygiene and something like that. So in that case, what will be our next outbreak? And when it happens, are we ready to face it, sir? Thank you.
Okay. Outbreak can happen anytime. You can't really stop the outbreak.
Anytime.
Anytime. It
Anytime
just
or anywhere.
because it's the matter of how is it the hygienic in that particular area. It's like illness. If you sit inside the emergency department, yeah, the hospital there's emergency department in it. You call darurat, isn't it? You can see always every day people come with cough, fever. Always can see people come with abdominal pain, diarrhea. That is a common. 70% people illness every day, cough, flu, fever, abdominal pain, diarrhea, vomiting. That is common. Why is it happen? Because in our body, yeah, our body, we have our own ecosystem. Yeah. So if there is immunity is disrupted for certain reason, it can be due to, that's why I say agent host environment. Don't think. If the host, we are host, our body is very strong. I have all this vaccination, influenza, pneumococcal, whatever, influenza. So you might get protected from this germ anytime. Okay? But doesn't mean that can stop you from getting this disease because you already protected. So agent host environment. But the agent itself, it can be multiply more virulence. That's why in COVID, remember, a lot of strain and become more virulent or become less virulent. Yeah. So the virus are so smart. They are all living things. So that is agent. The environment for the modernization, I'm sure you also wanted to have big building, yeah, all the infrastructure modern like in United States or in UK, yeah. What happened to the ecosystem? They will slash all deforestations. All these mosquitoes is living in the jungle. That's why now, even in Sabah also, we are worried about when do modernization, you want to do this, do that, you have to be careful about the ecosystem of this because they will create, the triad will become problem. So change the environment. The monkey now go to the urban. Then you got diseases like mosquito. No, mosquito will go to the urban. Where do you want to live? Because there's already no more trees. So after COVID, if you ask me, it will be a next outbreak. Yes, it will be always outbreak. But the difference is smaller or large scale. Smaller, you call sometimes clusters, or can be just a small outbreak, or call it epidemic. Or if you remain like that, you call it endemic. But it can't be transmit to the all over the world like COVID, we call pandemic. So pandemic is declared for 2019. That's why it's called COVID-19. We didn't heard about it. Even my life also this first time. But it happened in 2008, 1918, isn't it? Last time, the H1 influenza. So what's next? If you're not really careful, because we already, the immunity, the host, we can take a jab, take a vaccine, take care of your hygiene. Yeah, you live in the modern area, then you have less opportunity to get infection. Right? Environment, means that you control environment. The germ itself, you have to be monitor from time to time because there will be a virulency according to that your own nature. Yeah, so I can tell you, probably we won't heard about more bacteria, but we will heard about a lot of virus outbreak because bacteria can be controlled by taking the antibiotic. Malaria very easy. You can just take antibiotic and go got the treatment. But the virus, we don't have. We don't have. Usually we did this vaccination. So I can see that those who are taking this course, you need to enrich yourself with all this skill. There will be a lot of challenges in the future. You can be see in your area or you can be posted somewhere. I got the opportunity to be posted because I'm a FATP, EIP, Malaysia called EIP. So there's an outbreak about what is it, in Congo. What's the name of that? Almost. This is only confined to Africa. So Malaysia sent the team to help to do more on active case finding. Yeah. So take this opportunity to work with. When I was in WHO as a remote surveillance officer for 6 months, so I see a lot of a student coming. So if you can have a trip to WHO in WEPRO in Manila, we are monitoring the whole ASEAN country, how they manage the outbreak. Every day there's an outbreak. You can be shocked. You can see a lot of outbreak. But the pity things that the country who don't have the capacity, like Guam, the island, small island, they don't have the capacity to notify. They don't have the capacity to respond, to investigate. And then what they have is only few cases died, and then for unknown reason. So you will blame the whatever is the negative thing. So we must be prepared, in terms of knowledge, get as much as possible the experience from the established setting. Inshallah, you'll become a good disease detective. Did I answer your question,
Okay,
Zulfikar?
Zulfikar, you got it, yeah?
Yes, thank you so much, sir.
Yeah.
Okay. Nice question and nice answer from Professor Safri. And here still one more. Maybe I can give your opportunity to asking directly to Professor. Please, Mr. Azri Raihan, is from and say where do you come from? Undergraduate. Okay, still unmute. Yeah.
So first of all, I would like to express my gratitude for being able to join today's webinar activity, and thank you for the opportunity to ask question. I am Azriel Raihan from the Faculty of Public Health, North Sumatra University. So, Prof, here is my question. What are the primary methods of controlling occupational infection, and how do they focus on the source, transmission route, and worker protection? That's all for my question, Prof.
I'm sure you already learned about the hierarchy of control in occupational health. What is the number one? The hierarchy of control. Do you know that?
Hierarchy control
Elimination.
in occupational health.
Elimination, isn't it?
Elimination, Prof.
Yeah. So that is overall occupational health. First thing, you try to eliminate the hazard. You can't really eliminate, you go down, you try to substitute with less hazardous. Huh? If you can't really substitute, then you some people go for engineering control, try to maneuver the things that maybe become lesser in terms of magnitude and durations. You can't really have engineering control because it's a bit costly, then you go to the administrative control, maybe by rotation or shift. If you can't really do this, then the last one is to protect the workers. That's why I call PPE. Yeah. So your question just now will come to outbreak investigation where we should go. You always try to stop from the source. That is the ultimate rule. Yeah. That's why if you can see, if you in the movie, you find the source, you can get the source, and then you try to isolate. That's why the term of isolation, try to isolate that people, the germ inside the people won't be spread to the another people. You have to take out and put in the isolation. That is the best. But during the investigation, it's difficult for us to find the source. That's why we have to stop the like a lot of probably big highways. Highways like a route. So from A to B, A to C, A to D. So which one you need to stop? You put a police aside a roadblock. Can? So you can say airborne. You are sure about airborne from the history, then quickly you stop for the airborne strategy. If you're sure it's due to waterborne, then stop from waterborne. If you're from the usually foodborne, or it can be any vehicle. Sometimes like in hospital, even the instrument can be transmitted between the patients. So your ultimate goal, try to go to the which one is then same time you try to protect the workers, like missiles usually. Missile, we don't know who are the source. So many, and then they're very rapid. The R0 is very fast. So don't waste time to find the source. You better protect others by giving all this vaccination. So a lot of people will be covered up, well protected, and then already it's already probably from contact, then you're able to control. Yeah. So you see the situations, but the concept is still the same. But you doing investigation is probably continue again. Usually I have a team always update me where is it the source. If you don't know, do this, do that, try to. So they are focusing on it. What we call that is we have RRT or RAT, Rapid Assessment Team and Rapid Response Team. So they will do assessment. So you can have a good answers later on. Yeah. So quite challenging, but it's very interesting if you know the answers. Usually, when we know the answers bingo, then we will celebrate because we try to solve the case, yeah, while finding
Ah,
source.
hi.
Okay. Well, Azril, you got it?
Thank you so much for the valuable insight and explanation, Prof. I think that's all. Thank you, Prof.
Welcome.
Yes, we need to make a team in here, yeah, and try to find with the source with the investigation. Okay, thank you, Prof. Safri. We back to the chat feature maybe. In here, the participant from another faculty that it's come from UWin Su, Winsu Public Health Faculty, Mrs. Nurul Hassana Lubis. And in here, she is asking about what are some common healthcare associated infection in Southeast Asia and why they particularly concerning for workers in the healthcare sector. Maybe you can answer
I think
indirectly.
in the slide it's already stated
Yeah.
common diseases. Yeah. So usually we don't usually TB, tuberculosis through airborne. I think that is mostly at the primary care clinic, where actually the patient will come to do probably during the smear positive positive sputums. They will have this potential to spread the disease. And the other one is by bloodborne, is Hep B, Hep C. But the most important thing in what actually the control measures. So what happened in my experience, actually I forgot one slide for the TB. I have a few cases among hacker worker, my staff. I think nearly 20 have tuberculosis. So I did active case finding the whole staff, and then turned up to be additional 5, it become 35. So when I zoom to that, where actually the focus, I mean, which clinic? We have few lot of clinic. Yeah, we have child and women clinic, and we have outpatient clinic, and we also have like chronic disease clinic like hypertension, diabetes. So apparently we found out that it mostly is about the outpatient clinic. And so people, we don't know what is that. Usually you can come any type of diseases. So all the 25 staff is infected from there. But we can't find the source. So quickly we know that it's airborne. We shut down the area for a while for cleaning, and then we quickly uh, give them medical leave for those 25 students, 25 staff. And you know that the treatment is up to 6 months. You give them intensive for 2 months for daily dose. So the next is, once we clean up the outpatients, we need to open for the public, isn't it? So we create to prevent it, we create a triage counter. Actually, what we call is a cough and fever counter. So those who have before you come to the clinic, if you have cough or fever, then you will go to another one dedicated clinic where actually the staff is rotations you there, and then you have to have extra PPEs. So that will be a good. So from there we can see that no more cases, but they still can happen anytime because we don't know who have TB, isn't it? Unless we do a test. And bear in mind that TB very easy for us to be missing the diagnosis because uh, even though it's smear positive, sometimes smear negative also can be a TB. Okay, and the other one just like bloodborne, B and C, we have this mechanism where actually to screen the status of Hep B status. Those who don't have this antibody, we need to give a jab vaccination for them to be protected. Yeah. Okay, those is usually doctors, nurses, they must have that status. Yeah. And then where the area usually have this needle stick injury, usually in the medical ward and surgical ward, because a lot of blood taking during the morning, and then those who's the young one, the new graduates. So we have a KPI of zero needle stick injury. So you make sure that everyone must be complied with. There's one innovation to do to take blood by using the retractable needle. You know, retractable needle, the needle goes inside the syringe, so you won't get the stick injury. So this is another innovation we actually to protect, but only for the high risk procedure and high risk areas. So these are two things in Southeast Asia. Usually you can see common uh, diseases, infection in the occupational setting.
Okay. Okay, thank you, Prof. I hope you can answer for Nurul. Yeah, and we continue. Maybe it here, she need more explanation about your experience, Professor, about the migrant workers and what is how it's the higher incidence of infection disease compared with the local population, maybe the local workers also. It is a question from Merinta, Faculty of Public Health, USU. Yeah, why do migrant workers in urban areas have a higher incidence of infection disease compared to the local population? And how do the pattern of infection among the migrant compared to those local?
Okay.
Maybe you can more explanation,
Yeah.
Prof.
Yeah. So it's not really higher incidence in urban area. It depends on type of setting. Yeah. Uh, those who's in the urban usually maid industry, housemaid, maybe that. But I'm not sure about your kind, but in Malaysia there will be a screening process before they got the visa. So everyone must be screened by the what we call it FOMEMA. So you make sure that the common diseases like TB, all these blood, even STDs, HIV, this must be screened first. Yeah. So once they got this, they can't really allowed to go in. Okay. But we can't really help also, like in Sabah also we have illegal migrants lah. Illegal migrant because of the political reasons. I would say that the pattern is the contributed by the environmental factors. If you live in the rural area, they're mainly due to the vector-borne disease or waterborne disease because of the environmental part is already disrupted. In urban, usually more on airborne disease or foodborne disease. Yeah, airborne usually is a viral cause. Foodborne usually because of the food, like small eateries. They're all selling food, not really, it can cause food poisonings. Yeah. So if you ask me, migrants doesn't really specific pattern for diseases, but is the pattern is looking into the setting where actually they are. It's not really by migrant status. It's not. It's not due to migrant status. Yeah.
Okay, so the important thing to save that is the screening, yeah, from the
Yeah.
immigrant
Yeah.
coming to our country. And next question, Professor. Maybe in here there is Mrs. Nofrika Silalahi. She is confused, I think, because she is just want to know how is the relation, maybe, with the patient relation from the waterborne or vector-borne disease, giving the impact for occupational health. And maybe in here, she giving the particularly disease like leptospirosis and dengue fever.
Okay.
What is the impact for occupational health?
Yeah. So this is the umbrella of occupational health. Yeah. So under occupational health, there will be occupational infections. So we're talking about just now the occupational infection, waterborne, vector-borne. It also happen in the workplace. Okay. So people working at the area actually most of the time because of disrupted of the environment, so you can have this vector-borne. Yeah, for example, like our tourist guide. Yeah, if you go to the jungle, they are prone to get malaria. So you have to take a prophylaxis quinine for malaria. So it means that they are all the health of the tourist guide will be compromised. Yeah, so the way is try to do is just to do what we call that periodic examination, and also uh, giving them prophylaxis before you go to the particular high-risk areas. Yeah.
Okay, thank you, Professor. I think all of question in chat feature and directly question finish, we can answer it. And you have explained in more very high insightful for them. And I think the time is finished, and thus we conclude our top scientist webinar session. And thank you, Professor Muhammad Safri bin Zafri, for your outstanding contribution and invaluable presentation. And thank you also to all participants for your participation. We hope that today's discussion has provided new insight and inspired for us all to continue developing ourselves in the field of public health, especially regarding occupational health and disease. May the knowledge we have gained today be the beneficial, ya. Semoga bermanfaat. And I closing this session with a pantun again in Indonesia or Malaysian language. Jalan-jalan ke Kinabalu bersama Abah, tak lupa menikmati kuih jala dan ketul. Habis sudah berbagi ilmu dari Universitas Sabah, patut kita beri ucapan mantul. Mantap betul. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Assalamualaikum.
Waalaikumsalam.
Thank you very much, Prof. Safi, for the outstanding presentation. And for Dr. Eka, thank you very much for excellently moderating this guest lecture. And now we're gonna move forward on the fourth agenda. It's the awarding of a certificate to our distinguished speaker and moderator. With great respect, we invite the third Vice Dean of the Faculty of Public Health, Universitas Sumatera Utara, Professor Eti Sudaryati, to present the certificate for the speaker first. And we're gonna take a screenshot for the session. Okay.
Thank you.
And then the certificate for the moderator, we invite the third Vice Dean of the Faculty of Public Health, Universitas Sumatera Utara, Prof. Eti Sudaryati, to come to present the certificate for the moderator. Okay, we're gonna take a screenshot again.
Okay. Thank you, Professor Safri, for insight related to occupational health. As we appreciate you, we would like to deliver.
Oh, Prof. Eti, I'm sorry, but your voice.
Okay, sorry.
Okay, Prof.
Okay. Thank you, Professor Safri, for a fresh insight related to occupational health. As we appreciate you, we would like to deliver the certificate and collaborate further in the future. Thank you.
Thank you very much, Professor Eti. And now, as we come to the end of today's agenda, I would like to express my heartfelt gratitude again to our esteemed speaker, Prof. Safri. Thank you once again, Professor, for generously sharing your time and expertise with us. That was really enlightening and enriching presentation for today. And to our moderator, Dr. Eka, and to all the organizing committee and all participants, we hope you find it valuable and insightful from this webinar. Also, we are pleased to inform you too that all the attendees will receive an e-certificate, so kindly ensure that you have filled and complete the Google form to be eligible for that. Thank you for your time and participation. See you at our next event. Assalamualaikum warahmatullahi wabarakatuh, and have a wonderful day, everyone. Thank you.
Waalaikumsalam. Thank you.
Thank you, Professor Safri. Nice to meet
Okay,
you.
bye. Bye.
Bye.
Assalamualaikum.
Waalaikumsalam. Suara Bu Eti nggak kedengaran.
Thank you.